All right. Good morning, everyone. Welcome to everybody. We already have a big crowd online. Appreciate everybody joining in. This is actually always an important talk for us to hear, not only because of an important topic, but because our medical licenses depend on it. As everybody knows, you need 1 hour of opioid education every year. So Dr. Shu has been gracious enough for the last few years to help us out with this, as this is an area of significant interest and research for him. And today we're excited that Dr. Wally is going to be helping him with the talk today and the presentation. Take two, I'll just say hi, good morning. You want me to try talking again?
Sorry, I don't know what happened, but it's working.
What about our?
Good. I was the only person who saw that thing.
Small black spot in your field of vision, Joe, you're fine.
I've been there before.
It's this message.
Oh, got it. So,
There were a couple of hockey matches, but that's all I can see.
Okay, let's try it again.
all right. Take two. Apparently, everybody on Zoom could not hear for the first little bit of that. And I had mentioned we had a nice crowd on Zoom, and we've got another 10 people on since I started my first introduction. So welcome to everybody. Our CME color for this morning is going to be red. Dr. Shu and Dr. Wally are going to be sharing some of their experience with opioid monitoring and management to provide our opioid update. Appreciate them also being flexible. They were supposed to do this in December, but we had to make a quick date shift in order to get Dr. Frick to talk to us a couple weeks ago before he left town. So without further ado, I'll invite Joe up as he's walking up here. Just a reminder, in a couple of weeks on Saturday, I think the 21st, we have the Perry Initiative program coming up. So we've had great help from all of our residents and faculty in terms of providing mentorship and leadership and teaching for all of the high school women who are part of that program. So hopefully you guys can have that on your calendar and be part of that day. It's a really important thing for us to do and has been super successful.
And the king cake is hard.
And the king cake for faculty dinner the night before at Dr. Shu's house has been ordered. So, thanks, Joe.
Awesome. Thanks, everyone, for coming to our talk, which is mandatory. So no wonder everyone's so excited to be here. I'm also really excited to be able to share the podium today with Dr. Wally. Many of you have known her for many, many years, and Dr. Wally's gone on to get her PhD and really become one of the leaders in quality research, electronic health record transition, patient-facing material, compensation, physician compensation, the list goes on. So these are disclosures, these are relevant. Much of the work that we do, Dr. Seymour, Dr. Wally and myself, is funded by the CDC, and then Dr. Wally is also working closely with our own Dr. Natty Hammett on the Duke Endowment Grant for round 2 of CORE. So this is why we're here. We're here to learn, but we're also here to keep our medical licenses. So if you look at North Carolina, South Carolina, Georgia, it's relatively about the same. We'll soon in forums like this be welcoming our newfound colleagues in Wisconsin, Illinois, and Alabama. I don't know what the regulations are in this state, but we'll find out pretty soon. So talking about opioids and challenges around opioids, guess what? Our pandemic didn't help. Situation actually got worse with drug overdose deaths within the United States over the course of the past few years. If you look at the drugs involved in this, though, it's less and less prescription opioids, and we'll show you a graphic of how that's changed over time. Unfortunately, as we've discussed, we discussed this a little bit last year. The genie's out of the bottle, and now illicit fentanyl is really become the leader in opioid-related deaths currently. Most of these are polypharmacy as well, so there's multiple medications or multiple drugs involved in a lot of these deaths now. Some of the good news is that, although maybe it's not good news, but some of the good news that as we're identifying potential opportunities, and those opportunities are less and less around the prescriptions and really more around helping manage substance use disorder, mental health disorders, and even some harm reduction strategies like naloxone. And we'll discuss some of that work as we move forward. And so what you'll see is that as we're shifting as well, even within orthopedic surgery and the physician group, as we're shifting towards focusing on some of these other opportunities as well. So this is 2006. And what you see is as it gets darker, the darker colors are basically prescriptions per 100 people. And so as you get over 100 per 100, that means that these are states that had a opioid prescription for man, woman, and child. So up to about 2012, the states were getting in these darker colors. I just say darker or lighter because I'm colorblind, so I have no idea what any of these shades mean. They're just darker. And then as you see, fewer and fewer prescriptions per state per person over time. But as you saw on the previous slide, deaths continue, and non-fatal opioid overdose continues to rise. And as I said, I think a lot of this has shifted to people transitioning to illicit drug use, and so those are some of the targets for our future interventions. As many of you know, the CDC released guidelines in 2016 on opioid prescribing. These focused really primarily on chronic pain. There was one of the guidelines, guideline number 6, that actually had some information around acute pain. The rest was chronic pain. And what happened is, unfortunately, some of this stuff got a little bit misapplied. And the intent of the guidelines were to be voluntary and to really support and not replace patient-centered care, which a lot of it actually did. And so some of the unintended consequences that we've seen, not only in the news, but in the peer-reviewed literature, was very, very rapid opioid tapers or abrupt discontinuation for people that had been on chronic opioids for many, many years. States, pharmacies, insurers took on rigid application of various thresholds and duration limits. And unfortunately, there have been cases of patient dismissal and abandonment that resulted in dire consequences for those patients and even death. And so there really is, even though the intent was not that, the intent was really around a balance of safety and comfort. One of the things that occurred in 2022 is the updated CDC clinical practice guideline on opioid prescribing, and actually was not only just chronic pain, since there's a very small slice of U.S. physicians that manage chronic pain. This was both acute and chronic pain. And as many of you know, as some people and a lot of people in this room participated in our acute pain for musculoskeletal injury guidelines that we did with the OTA. Those were actually novel at the time. We really didn't have anything for acute pain prior to that. And now some of those panel members from that actually participated in this along with me. I was fortunate enough to be selected to participate in this update of the CDC guidelines. And again, if anyone is interested in spending 2 years of their life reading papers and sitting on meetings, just let me know. We can get you involved in guideline development. For some reason, I keep getting tapped to do this, but it's actually pretty interesting. This group is a fairly diverse group. There are physicians of all different types: pain management, anesthesiology. I was one of the few surgeons on the panel. And also patient advocates, patients themselves. For these things that come out of anything out of a federal agency, they have to go to an open comment period. So this actually went through several months, where it was available online. And so some of those comments, even by the great American public, were integrated into this. So I'm going to break my rules around slides for you and show you slides with a lot of words on them, but I've highlighted just the words that we're going to talk about. So that you don't have to go through and read the document, but you can go through and this is where you can go on the CDC website and download the entire document. It's actually not that long to read. The references are really, really quite good on it. But we'll go through the recommendations. There are 12. We'll go through them very quickly, and then I'll turn it over to Dr. Wally, who is really going to demonstrate a lot of the stuff that we've kind of built in to the system for you. And so, and you can see how much support we've kind of put around making sure that you are compliant with these guidelines or optimizing your patient care within the realm of these guidelines. The recommendation number one right out of the gate, and I always think number one tends to be the most important. That's why people would make it number one. But actually, I talked about the data around non-opioid therapies. And when I say non-opioid therapies, this is non-pharmaceutical strategies. And so we've talked a lot in this forum around true multimodal pain management, which involves physical and cognitive strategies. Physical strategies like cryotherapy, massage, TENS units, cognitive therapies like inhaled essential oil aromatherapy, some of the meditation, as well as some of the other relaxation strategies, music-induced analgesia. We spent one of these talking about as well, and so really focused a lot around that and went through some of the data on that as well. And then really what you'll see a lot of the language throughout the guidelines is really about risk-benefit analysis of opioid therapy. Not saying you shouldn't use opioid therapy, but really risk-benefit analysis and having that discussion and weighing that with the patients, giving the data and the information that we know now around opioid therapies. So again, recommendation number 2 is still a multimodal style recommendation, but this is really so recommendation 1 was really about acute pain. Recommendation 2 is subacute and chronic type pain, and really maximizing the use of non-pharmacologic agents as well as the non-opioid pharmacologic therapies. And so some of the stuff that we've talked about and taught here is really those things that are scalable and accessible. And so strategies that are affordable by our patients and available regardless of their communities. Other things that are pervasive throughout the newer guidelines is discussions about when and how to discontinue opioid therapy, and when that risk-benefit analysis really flips for the patient. You've heard me discuss before, start low and go slow. These aren't my words, these are borrowed from people much smarter than me. But really hitting hard on recommendation 3 is to stick with immediate release opioids. We got into a lot of this situation with extended release long-acting opioids, which more and more data continues to support. Data we've talked about for the past 5 or 6 years here is that the extended release long-acting opioids have not proven to have any additional benefit compared to short-acting opioids. And then again, lowest effective dose. Multiple papers have come out in a variety of different specialties around the amount of opioids that people actually use in our world, in the surgical world. You name the specialty, we've been able to show that if you prescribe 40 pills, most patients don't use that much and then have them in excess, which actually become an opportunity for diversion or abuse even by other members of families or friends. And then if you're in a situation where diminishing returns are expected for increasing opioids, these discussions need to start again. So when recommendation 5 is really focused on those patients that are already on some type of an opioid therapy, and even showing data that introducing non-pharmacologic and non-opioid therapies at that state for people that are already on opioids, and we see this a fair amount. We see people that are going to the pain clinic and being treated for chronic pain that are on opioid monotherapy. And it actually turns out that there's data that adding in some of these non-opioid strategies can help. The other thing that I think is important too is that opioids should not be discontinued abruptly outside of a life-saving measure acutely. And so those things need to be tapered over time, since there can be really negative consequences for those patients. But those tapers don't necessarily have to be done by pain management specialists. We can help participate in those tapers. That's one of the goals for 2023, at least in the perioperative setting, is to give all you tools to help patients taper that. And there are some data out of some pain researchers that actually show that patients are able to help self-taper if given a little bit of guidance for how to do that. And then again, recommendation number 6 is fairly common sense, is prescribe no greater than the quantity needed. As we discussed, patients often have a lot of pills left over. We talked a little bit about evaluating the risk benefit ratio for the patients. And this is not only a one-time evaluation, but reevaluation throughout the course of the patient's treatment. And they even gave some recommendations. Number 1, evaluate the benefits, risk and benefits up front. But then if you're starting an opioid therapy within 1 to 4 weeks, and so that actually works out perfectly for us in the perisurgical setting, because we're going to reevaluate that essentially on a weekly basis to see if people can continue to follow that taper or what needs to happen. And then if there's a transition to either subacute or chronic pain or dosage escalation, those risk benefits need to be weighed again and discussed with the patient. One of the things, again, that's in recommendation 8 now is really discussing the harms as well of opioid therapy with our patients, and really discussing the use of naloxone. And as many of you know, in our health record that hopefully is transitioned over to Epic, Dr. Wally will be the expert on that now, is that if you prescribe over a certain morphine milliequivalent, that it will prompt you to prescribe naloxone for the patient. And I think that not only is that a rescue drug for having an issue with an opioid, but it actually prompts a discussion. It helps you prompt the discussion around the risk for the individual and for families of patients with opioids in their home. And then there is a strong recommendation, again, recommendation 9, which is actually consistent with a lot of state law now, is to look at the state drug monitoring program, whether you are initiating, continuing, or escalating opioids in a patient. And then for those patients with subacute or chronic pain, the recommendation is for toxicology screening to make sure, as I stated before, and I showed you in the overdose deaths, they're usually polypharmacy. And so they're patients that are also using other substances. And so toxicology testing would be important. Interestingly, too, with toxicology testing, if you have someone that's on, I don't think we have people that are doing a lot of chronic pain in this particular audience, but one of the things actually testing for with toxicology is to make sure that they're taking the opioid as well. Some of these places that got into real trouble, they had patients that were being prescribed massive doses of opioids, and they did not have detectable opioid in their system, which meant that they were diverting the opioids. And then the last 2 recommendations are, and as we've discussed here, you've heard it for almost 10 years from Dr. Seymour and I about co-prescribing benzodiazepines and opioids, and that is in our outpatient alert as well. One of the tools it does in the logic is to go through and make sure that the patient not co-prescribed a benzodiazepine. 10 years ago, when we started talking about this, I don't think anyone cared about benzodiazepines, and now within about the last 3 years, people have realized that this is a really big problem, not only by itself, but being co-prescribed with opioids as well. And then the final recommendation is for when it comes to detoxification or taking patients off a chronic opioid, is that better success occurs with medication-assisted therapy as opposed to weaning on its own. So I'm going to pause here and bring up Dr. Wally, who is going to take it from here. And this is where you're starting, right? All right, good. So again, I gave her a little bit of an introduction before, but I think most people know Dr. Wally, who's going to really get into the meat of this talk. Thank you.
Morning. So I wanted to start just with a reminder that there's a lot going on at the state level around opioids. Dr. Shu went into more detail on this action plan last year, but you can see that the focus areas on the slide. I'm not going to read them to you. A lot of it is around the illicit drug use and kind of downstream effects of opioid use disorder for incarcerated populations, and primary prevention around unemployment and lack of insurance. But you probably know that there was a settlement with the pharmaceutical companies, and North Carolina specifically will be receiving payments of $750 million over the next 18 years. And that money, you can see on the chart on the bottom right, has begun being distributed to the state and will be for the next several years. You can look at these. There's really cool dashboards on the state website that you can see that the rate of North Carolina residents being prescribed opioids has dropped dramatically. And while there's still an increase in the deaths from illicit opioids, but there's also been an increase in patients receiving treatment for opioid use disorders. So relatively good news. I want to take a moment to say congratulations to all the Atrium Health employed physicians. We had a physician compensation goal around adherence to the STOP Act for orthopedics, or it was around 7 days or less duration of all prescriptions. And you can see they just knocked it out of the park with over 90% compliance. And for primary care sports medicine, they had a new goal this year regarding checking the PDMP before prescribing. And they also showed dramatic improvement from 40% up to 80% with the EPIC rollout in the middle of that. So great work, everyone received their incentive, and we hope this is providing the best care for our patients. I also wanted to take a moment to thank and acknowledge our quality team. I'm going to share a lot of resources that are the work of a big team of people, and I feel really lucky to work with all these individuals who are doing just phenomenal work. So I'm going to show you several resources we have available that you can start using immediately, and I hope will be useful to put the clinical practice guideline into your practice and support you. They are also all available on our website if you scan this QR code. And those are all Atrium branded materials, but we also publish them unbranded in a recent JOT supplement. So if you have colleagues at other institutions that are interested, please feel free to point them to the unbranded materials in that supplement. First, I want to talk about the opioid sparing pain management order set. This, I think most of you are familiar with. We began developing it in 2017, so quite some time ago, and then it was part of our Improve intervention funded by the CDC, and went live in Cerner in 2019, and since then has been used in over 4,000 patients. The update I have for you is that the MSKI Quality Advisory Committee, which is co-chaired by Dr. Kempton from Greater Charlotte region and Dr. Shields from Wake Forest Baptist, took the order sets from both institutions and took the best components of both and also just updated the order set. So this includes the non-pharmacological modalities, and it really maximizes the non-opioid pharmaceuticals and then adds the opioids if needed. So I encourage you to check that out. You have to search opioid sparing in EPIC to find it. So in purple, you can see the name of it from an EPIC screenshot. The other exciting thing is we can embed it into existing order sets. So we just last month put it into the orthopedic trauma admission order sets. So anyone that's interested in putting this in an existing order set, just let us know and we'll help you do that. Also from the Quality Advisory Committee, we created some new patient education materials I'm really excited about. These were distributed to all the practice managers. So they should have the information, but let me know if not and you're interested. They're all loaded into a platform where individual clinics can order whatever quantity or format, size, et cetera, that you want. So whatever suits your practice, you can have flyers or posters hanging in your clinic. They're also available in English and Spanish, thanks to our translator, Dr. Reese, and branded for each specific region. So there's Wake Forest Baptist, Floyd, Navicent versions as well. And they've been approved by Health Literacy. So this one I really like because it is just a front and back flyer, but it has the QR codes to direct patients to additional information if they would like. So it has is formatted in a myths versus facts. So it's really small on the screen. For example, meditation is not for me is the myth, and the fact is meditation might seem hard if you don't know how to do it. We can give you links to guided meditations you can listen to. And then if they scan that QR code, they would get additional information. And these all existed previously, but now we have just one easy flyer that has all the information. So if you were to scan that QR code, then that would direct you to additional information on cryotherapy. We also have a new flyer, also just a one-page front and back about just acute pain management in general, trying to educate our patients about this concept of multimodal pain. So it gives them instructions for prioritizing and using their over-the-counter or non-opioid medications first, and then bringing in opioids as needed, and also directing them to the non-pharmaceutical modalities and acknowledging the importance of using opioids for the shortest amount of time as possible. So again, these are all on the website. You can also have your practice managers order them to have on hand in your clinic. We're working on trying to get them built into Epic. We also have a new tapering guideline for post-op. So these are based on the OTA clinical practice guideline that Dr. Shu referenced. And there are 3 separate tapering schedules based on major injury or surgery, minor injury or surgery, or non-operative. So these are not meant to be patient-facing, so they're not approved by Health Literacy, but they're intended to just be useful to you. So if you want to print them out and have them in your clinic for you, that'd be great, or if you just want them somewhere to reference. Like Dr. Shu said, we're also working on a preoperative taper for 2023. So we hope to share that at this update next year. And then finally, just wanted to highlight our publications in the opioid and pain management space. We actually had our most productive year this past year in 2022. And this has been a great way to engage learners in our research. And we are expecting an even more productive 2023 as all the papers from the original course study that Dr. Hama did begin to be published. And if you're interested, this QR code will take you to all of our publications in opioids and pain, and we update it quarterly. So thank you, and I hope these resources are really helpful for you, and I can invite Dr. Shu back up, and we're happy to take questions.
Thanks. We wanted to leave time for it to be interactive. There's already been some questions on Zoom. We'll send this slide deck around so that everyone has the QR codes, or the video will be put up on the website, and so you can just pause the video and take pictures with your phone, and it'll put you right on the website to have these materials. Dr. Pat.
So first question, one of the things I liked that you had up there was your theory on start low and go slow. So any recommendations for how to start low? So when I have people who we are going to give narcotics to, I think we can give them a 5 milligram Norco and tell them to break it in half. But it would seem like a body like the CDC might have the ability to say, hey, let's make a 2.5 milligram. Let's make a smaller dose, because really, if you tell somebody to break a 5 in half, that's an additional step for them. So it's not easy. So any thoughts on that? Was that discussed at all? Because I find that, especially, teenagers, I don't really want to give them 5s, but you do a significant operation on them and you have to have at least something available for rescue, and I don't want to give them that much.
It's a great question. One of the things that actually happened in the transition from the 2016 to the 22 guidelines is they took out almost all the numbers, because what happened is if you put any number in there, I don't know if you remember, 90 or 100 morphine milliequivalents was put in as a number, and so then that became like the number, which was, again, it's a statistical finding from different research studies and well supported, but people kind of just jumped on that number, and so we stayed away from all numbers to a certain extent. As far as drug dosages and the pills and everything, that's a different agency of the federal government that's here to help you, the FDA. No comment. And really driven by the pharmaceutical industry. But having said that, I tell the patients to get a pill cutter, and then they feel like they have a tool. I think at least our patients feel like they want a tool or a gadget or something. It's like, oh, you go to Harris Teeter, not that I have any financial relationship with Harris Teeter other than giving them a lot of my money. It's like $6 but then they feel like they have a tool and they feel like it scores appropriately. And so that's been my strategy for people cutting pills. And that's one of the nice things about a short-acting opioid is that you can cut it. The longer-acting opioids, you can't modify it or else you get a dangerous immediate release. Great question. Yes, sir.
Joe and Megan, thanks for your presentation. You all really become national leaders in this space, and that's great. One of the things from working also on consensus statements in my past, sometimes it's hard to decode these recommendations. So you have categories and you have levels. Can you briefly discuss that? Is that the same as levels of evidence like we have in the literature, or what is the code for that? How do we apply those recommendations?
I'm not going to do a good job of knowing it off the top of my head, but it's hard to get the highest grade of evidence. That's like multiple meta-analyses.
So it's a grade criteria, which is level of evidence or the strength of recommendation.
Yeah, so A, I think I want to say it's like meta-analyses, and then B is prospective, maybe randomized, and then C is all the lower quality evidence. But there's also ways you can account for the volume. So if there's a lot of retrospective studies showing the same thing, it's a higher grade than one randomized trial, for example.
And the heavy lift with these evidence-based guidelines is going through the grade criteria. And Dr. Wally did the table for almost every subgroup for our OTA guidelines, 350 something references to go
So
through
like
grade.
A1 would be the highest level.
Would be the highest level.
Yeah.
So that's level 1 data or meta-analysis data and strong recommendation. And so some of the guidelines they may be strong recommendation, but the evidence is weak. Most evidence in any of these guidelines, as you know from doing it, a moderate level of evidence is about as good as you're going to get. There are very few studies. The challenges though, like have you done the Academy guidelines for the PICO questions?
Yeah.
How you set up the question can really set you up for success or failure. And so if you set up a very, very narrow question, there's 1 or 2 studies, you can end up with a very high level of recommendation. And so setting up the questions, it should be a little more broad to begin with, to incorporate more evidence, because you want multiple studies as opposed to some of these other guidelines I've been involved with. You end up with like 1 or 2 studies and it drives the entire guideline, which is inappropriate. That was a perfect example of that, is that vitamin C for the distal radius guideline, which was based on 1 study, but they asked a very, very narrow question. There was only 1 study that met the criteria. Same.
What are your recommendations for patients who come in on a chronic, let's say patients are taking oxycodone 10 for years, they have a new acute injury with new pain, we as residents are admitting them. What is your recommendation? Should we prescribe, do their med-rec and continue prescribing them oxy-10s and then add some because they have a new pain, or how should we handle the fact that they are already on higher level of opioids than we're used to prescribing?
Right. It's a great question. It kind of depends on the situation with the patient. I would say it gives you a good concept for where to potentially start. But a lot of times we've been able to admit those patients and use our multimodal pain sets have actually been effective because people haven't used non-pharmaceutical strategies or non-opioid pharmaceuticals. And when we've added those in, those have actually been reasonably anecdotally successful. It's actually probably worth a research question that we could potentially help answer with our own data is what does it look like for someone who comes in on a high MME, has a new injury, and what is their perioperative course, because some of it's pre-surgical and post-surgical look like. So that's, to me, that's our starting point for the most part. Some of the published data would say you convert their home dose to MMEs and start from there. But that's a challenge for patients that are on, some of these patients come in, they're on 200 MMEs a day. And to try to start there in that setting, I think can be a little bit challenging and dangerous. The other thing that I would tell you is not only with the pain order sets that we have with the non-pharmaceutical strategies, non-opioid strategies, is at most of the hospitals where we're going to treat a patient like that, we do have some resources in some of our anesthesiologists that potentially can do peripheral nerve blocks that can really help us out a fair amount in that as well. And so like even at Maine, they're really growing a regional anesthesia team that can help with that. And there's a very sophisticated team here as well. And so don't forget about that. And then for those patients that really are beyond what you would consider for chronic pain and really are in the category of substance use disorder, we do have addiction medicine specialists at a lot of the facilities that can really support that work. An example of those patients are, they come in polysubstances, high MMEs, or patients that come in that are actively injected drug users are some of the most difficult to use, to manage. And that's where I think addiction medicine is really very helpful. Dr. Scale.
The work y'all's team has done has been awesome over the years. What I haven't heard as much, and I wouldn't expect from the adult side, but are you aware of parallel things being done in the children's hospital? Because it's not, I don't know that that's been communicated as much to a lot of the physicians, especially the surgeons. We've done a lot of work in peds ortho, really following your lead. So that would be question one, is just what work is kind of being paralleled in the children's hospital? And then the other piece, how do you work to change the culture on the floor? So that's, I think, the biggest thing, and our residents can comment too, but there's a culture of patients, and particularly children, can't be in any kind of pain. And so that's been the biggest fight, I think, from an opioid standpoint, is the constant phone calls for narcotics. So what was done, or was anything done? I'm sure there was on the adult side, and what can we implement in the children's hospital to help kind of change that culture as well?
You're right. We focus mainly on adult, and it's probably about time we started focusing on the children, as you have already done and I've led. And so that's something we really should say, look, in 2023, let's partner on this and do this. Because as you know, our strategy isn't just orthopedics. Our strategy is entire medical group, education across nursing, across everyone. In your world, Child Life would have to be a part of that. And I think the way with Child Life, who sometimes, be very careful how I say this since it's being recorded. Sometimes child life with the greatest of intentions can actually create conflict between parents and families and the physicians. It turns out they can actually be one of our strongest assets, because some of the most effective things in children are actually some of the non-pharmaceutical strategies, completely non-pharmaceutical strategies: distraction therapy, aromatherapy, music-induced analgesia, very, very powerful effects, in multiple publications in the pediatric literature on how profound these effects are. And so those are in the wheelhouse of child life and some of these other types of people in nursing. And so they can really be the strongest advocates for that. So I think the strategy is, instead of saying, no, we can't do these, this is too many opioids and this other stuff, is actually empower them to be the agents of change and empower them and give them the tools to do so. And we kind of did that when we first started on the adult side. We really were having some challenges on the adult side. For us, we don't have child life, but we had a very active nursing crew. And it actually turned out that a couple of nurse leaders and then some just, nurses who were very passionate about this created different strategies. What was the cart called? Rachel, do you remember? They had like this, they did an NPR interview on one of our nurses who created a comfort cart. And so she had all these different things. She had aromatherapy on there. She had all these different things, and distraction therapy, and she'd just push it around the cart. And so she'd come into the patient's room that was having some trouble, and there would be a menu of things that the patient could have and immediately have access to. And that was not something that we directed. That was something we just created the environment, and they did, and we empowered it and promoted it. So I think that's really the strategy. And then we did initially ping a few, at your urging a few years ago, we started, and it kind of got a little bit foggy, and then the pandemic hit, with trying to do some order sets in the pediatric population. I think would help. And there is data that order sets like that do help in a pediatric population.
We've taken a lot of your work, plagiarized it, and used it in the peds world. So
can't plagiarize when we give it.
And honestly, a lot of it has been the residents' work that they've done to kind of use the same kind of approach and implement it in pediatric patients. And I think where we've done it the most has been with our spine patients. Right. And we've seen a dramatic decrease in hospital and out of hospital use of narcotics. Yeah,
and the stat I find there's a shorter length of stay with doing some of these because they have their gut situation. Dr. Pat.
Hey.
Someone else.
Yeah, hey, this is Jenny Casey. Thanks so much for this excellent presentation, as always. So this is going to sound a little bit like a joke, and it kind of is, but it really kind of isn't. So we have child life, and I agree they can help. But honestly, I think we need parent life. I find that the kids that really are struggling, where it's not pain related, but it's other things, a lot of times the parents are making things worse. And I wonder if parent education, either with or without the child, is also something to focus on, because I don't know that I've heard much about that.
That's great. You didn't hear much about it because I don't think I thought about it ever, but it's really interesting because there's a parallel with Trauma Survivors Network that actually has a family facing element as well, because what we realized, and what nationally has been recognized, not we, is that these family members have as much to do with it as anything else. That's a brilliant idea. That is a brilliant idea.
So, Joe, the answer you just gave to Brian, you made a couple of comments that referenced the conflict that's created by trying to limit opioids sometimes. And it's, usually satisfaction. People think that you're withholding care. Has that aspect been looked at either by the CDC or by our hospital? I mean, I can tell you at least one recently. I had a patient-generated complaint because she said we undertreated her pain. Yeah. And, we slowly dose escalated, and it was kind of inappropriate, the things that she was demanding, like outpatient Demerol. But she's a nurse, so she already knew the answer to that. But so the question there is, yes, and Brian said the residents do a really good job. They're the front line for many of us in terms of having those conversations with the families. But should there be some sort of resource at the hospital that we can sort of click on a button on the website to say, hey, this family's really upset. Can we have somebody, again, like Parent Life, like somebody intervening in those situations? Because those can get pretty nasty when people feel like you're withholding care. Has that perspective ever been looked at? I mean, it fits sort of well with what you just said about child life in terms of how they can, well-intentioned, but can create conflict because we want to make everybody happy. But that's hard sometimes in adhering to these strategies and these guidelines.
The second part I'll answer first. Do we have an inpatient group that can help with that? Not formally, that would say, hey, they're going to help mitigate this challenge with the parents. There are different resources available through nursing administration, whether that helps or doesn't. I've had situations that escalated over, not over that, but over someone canceled for surgery, and it escalates into upper stratosphere and sometimes is worse in that scenario. There also is the acute pain service that is developing. It's at Maine. It's not fully rounded out yet, but that's something that will help as well with development. So I think that coming soon, there will be resources for that. As far as patient satisfaction, there's data that we actually did a study, Dr. Karenach, Dr. Seacrest led, that looked at outpatient patient complaints through the Press-Ganey system. And it does happen, but it's actually really, really rare. I think it was like 2%. Do you remember?
Maybe lower than that.
It was pretty low.
Yeah.
It was pretty low, and it's concordant with other studies that actually showed that that the patient satisfaction is probably not tied to their opioid prescription either. It's what's interesting about the core study. Some of the new papers coming out of core studies that patients reported that their pain was better. The non-opioid patients, they actually reported better satisfaction, which we're all going to have those outlier patients to a certain extent, and that showed up in Dr. Seacrest's paper as well. But it was less common, and so I think that we can be confident that if we do opioid sparing protocols, that we're not just going to have 800 patients complaining about us every year. It can't prevent the outliers, but hopefully we'll have some resources soon for that.
And also, I'd like to comment that I think framing the multimodal where you're saying we're doing opioids or not, and these medications, and we're going to try all these things and see how that helps your pain, makes the patient feel like you're doing more to address their pain versus just an opioid, yes or no.
All right, anybody else online have any questions? All right. Thank you, Jack.
Thank you.